I'd like to welcome you to the Medical Center Hour and to Medical Grand Rounds, being held jointly today in order that both audiences may engage with our special guest, the Brodie Medical Education Award winner, Molly Cooke of the University of California, San Francisco. I'm Marcia Day Childress from the Center for Biomedical Ethics and Humanities, which produces the weekly Medical Center Hour, and we're grateful for Medical Grand Rounds to be joining with us, and I hope we've happily split the difference on the start time of this session. Today's session is generously co-sponsored by the Department of Medicine, the Brodie Medical Education Award Committee, and the Academy of Distinguished Educators in the Medical School. And this program is also part of the School of Medicine's slate of activities during our annual Medical Education Research Week. Preparing the Physician of 2030. This is a subject in which our sponsoring groups and their members have an intense interest and a substantial stake. When Molly Cooke sent the title for her talk, its subtitle felt both like a wake-up call and a prompt for some urgent and rigorous self-examination. The subtitle is, "We're Doing It Now." Yikes. Are we doing it right? The yikes was not hers, it was mine. For yes, as a medical school and as an academic medical center, we are already very much enmeshed in educating and training the next generation of physicians. And yes, we would do well to inquire on behalf of those students and residents who will be practicing just 18 years hence. That's the yikes. If we're giving them and if they're getting what they need to be good, effective doctors. Our 2012 recipient of UVA's Brodie Medical Education Award, Dr. Molly Cooke, is the William G. Irwin Endowed Chair and Professor of Medicine at UCSF, and the founding director a dozen years ago of UCSF's Hallie DeVos Academy of Educators. She's been at UCSF for more than 30 years, but she's also a national presence in internal medicine. Next month, for example, she becomes president-elect of the American College of Physicians. She's also a national presence in medical education. From 2004 to 2009, she was co-leader with David Irby and Bridget O'Brien of a Carnegie Foundation study of medical education. Their report, Educating Physicians, A Call for Reform of Medical School and Residency, was published in 2010, the centennial of the landmark Flexner Report. Their report calls for significant national and local change and strategic institutional realignments in the preparation of physicians for today and tomorrow. You'll find a much abbreviated biographical sketch of Dr. Cooke in your handout. We're ever so grateful to her for spending part of this Medical Education Research Week with us. She's brought us vast experience, bold vision, good humor, and practical wisdom, and she radiates a love for medicine and for teaching that's frankly infectious. She's helping to spark lively conversations throughout the School of Medicine about the work in which we're all passionately engaged and invested, the learning, teaching, and practicing of medicine. This hour is one more such conversation, and there should be some minutes at the end of the hour for you to join in as well. So please join me now in welcoming Molly Cooke.
Thanks so much, Marcia. It's a great pleasure and an honor to be here as your Brodie speaker. This talk, when Marcia and I first began discussing what I might talk about, I said honestly, recognizing that I was likely invited here because of the book that Bridget and David and I wrote together. I said, please don't make me talk about the book again. I can actually give that talk literally asleep. And so this is the maiden voyage of some thinking that I have been doing about exactly the idea that I hope I convey in my title. I look forward to hearing from you what makes sense, what you want to challenge me on, because that's how I'm going to learn. So with no further ado, let's get into our conversation about the position of 2030. So I'm not a futurist, but to get started on what we need to be preparing students for, I consulted, of course, the internet. And there are plenty of people prepared to take all kinds of positions about what healthcare and medical practice will be like in 2030. And to sort of set the stage, I thought I would run through a bit of this with you. So first, people, more than one person, predict with confidence that we will be using stem cells to regenerate amputated, if not limbs, at least digits. And for those of you with good eyes, I'm not sure that with the lights fully up, and I want them to stay up, so don't take that as a suggestion. But in this picture of a BKA, you can actually see in high resolution, you can see substantial vascular calcification. And people predict that that kind of cardiovascular disease ought to be essentially completely preventable by 2030. But it gets more dramatic. People predict that we will be using exosomes to deliver highly targeted drug therapy across the blood-brain barrier and to other locales where, at this point, we have to administer medication systemically at high toxicity, or we can't use drug treatment at all. This is a nanobot. Now, how people conceptualize nanobots varies fairly dramatically, but again, many people are predicting that we will be able to use nanotechnology to, at the sort of cell scale level, detect disease, specifically malignancy, as it's just getting started. Again, targeting therapy incredibly specifically, and one of the images even shows a nanobot integrating itself into a neural syncytium to replace damaged neurons. People anticipate that computational power will be expanded to such a degree that it will actually be possible to simulate closely or entirely the function of the whole brain, rather than much more circumscribed abilities that are now modelable with the computer power that we have available to us. And finally, the sweeping overall vision is that we will be on the verge of what people are calling ultra-personalized healthcare, based on detailed genomic information about each individual. People are imagining a national biorepository, stem cell storage for all of us, and what some people call stem cell pharmacies. And as Marcia said in the introduction, this all sounds like way science fiction, but to the extent that any of this is true or similar advances take place, it's really not that far away. So this fall's entering freshman, positing an average length of stay in medical school and kind of a generic residency of 4 years, will be 5 years in practice. They will be young physicians in 2030. And even this spring's graduates, again, imagining the generic average age medical school graduate, will only be in their early 40s. At the time that we're using exosomes for drug delivery and infusing nanobots to do this and that. So we really do need to be anticipating a future that is significantly different from the world that we live in now as we prepare our graduates. That future, though, is not perhaps as different from where we can already see medical practice going as it is from our fundamental methods of teaching medical students and residents. So I suspect that many of us have spent countless hours in settings like this, looking at PowerPoint slides. This one, you can't read it, but he's listing pre-op labs for the evaluation of some condition or other. And who knows how the attention of the audience is divided between his instructional content and breakfast, which is on many of their writing desks. But we know that this educational format is highly ineffective, but we still use it with religious devotion. And this kind of learning is not going to, I would argue it doesn't prepare people for what we're asking them to do now. And it certainly will not prepare them for 2020 or 30. So the answer to my question was implied by the fact that I proposed to give a 40-minute talk on are we doing it right? And my answer is no. And it's time overdue to really transform the way we approach educating physicians. So I'm going to suggest that there are a couple of things that we need to radically change. And the first is how we prepare our students to deal with the amount of information that they will need to manage and deploy and integrate to take care of patients. And associated with that revisioning of how we have physicians interacting with information, we need to change how we assess their ability to access, deploy, assess, and integrate information. And this kind of assessment approach, which it's not a perfect image, and I apologize for the resolution, but I kind of love the old-fashionedness of it. It conveys what I wanted to convey with everybody in there. These are probably British public school students in their matching ties. But this is fundamentally what we're doing. We're taking people outside the setting in which they really need to use all of this complex information, and we're testing them in terms of how much they can get from their heads onto these sheets of paper. Now, it's not quite the computer-based testing that USMLE and the various boards do, but really all that those agencies have done is move this activity to a different platform. So what's going on with this proliferation of information? I'll make a couple of points here. First, it is said, and I have no idea how people arrive at this assertion, but that the amount of information available in the medical world doubles every 8 years. And this image is simply intended to convey the fact that here we have 6 journals. This image may not be from yesterday either, so at the time the photograph was taken, there were 6 medical journals dedicated to the, dare I say, somewhat esoteric subject of redox signaling. And we all know that depending on your specialty, or maybe not depending on your specialty, important information can show up on a monthly basis in 20, 25, 30, an impossible number of journals, to say nothing of information that's critically important and that's available online. So medical information is just sort of torrenting down on us. And a particularly important form and source of this information, as I already alluded to, is genetic information. It's already no trick to, for $400, really get a substantial genetic characterization of an individual, and people have direct access to this themselves. This is a image of a GWAS study. I'm not going to, I couldn't, if I wanted to, explain to you what exactly this means. But there is, day by day, more patient-specific information becoming available, and people are eager for it. Maybe not everyone, but some people are. This is actually a very interesting book by Thomas Goetz, the editor of Wired magazine, basically talking, he's advocating that each of us have our genome basically sequenced and begin to approach our healthcare, and that means approaching us, the physicians, with detailed genetic information. A challenge here is that our cognitive capacity is amazing but limited. And it is said, based on basically research studies, that we can't handle more than about 5 relevant facts. We can't integrate more than 5 or so important considerations into a decision unaided, with just our brains. So here are these very brave people using just their brains, puzzling over we'll assume it's an important clinical problem. But here's how those 5 facts, and the upper limit is marked right above where it says human cognitive capacity, compares to the information that's already available and predictably coming available within the short-term future. So you can see the amount of excess information over the 5 facts that are attributable to structural genetics, to functional genetics, and to proteomics, and so on. What we do when we are exposed or subjected to more facts than we can actually manage is we just throw out a bunch. And we don't often do that in a particularly informed way. And often it's actually not possible to be highly judicious about what to throw out. We just get overwhelmed, and as a consequence, we oversimplify the decision-making set so that we aren't paralyzed. So testing people in the model that I showed you with, it's a one-on-one exercise of what I can get from my head, apply to a problem, and indicate that I plan to do, is already inadequate to the situation that we face in clinical medicine, and only becoming more inadequate week by week. This is a little bit, if a graphic can be jargony, this is a little bit of a jargony graphic. But I'm very fond of it because it represents, it's one way of representing the idea that knowledge, if I had chosen to animate the slide, I would have simplified it so that at the beginning you just saw the connection between the patient and the physician. What this graphic intends to indicate is that there's actually a huge amount of information in the environment in which the physician and the patient find themselves that is applicable to whatever clinical consideration you are faced with. So some of that information is embedded in things in the lower left-hand corner, sort of rules, routines, things we usually do, standards of performance we expect of ourselves. There's information in division of labor. I'm not going to elaborate on that because it's a little bit of a complicated idea that won't advance my case here. But what I want to particularly point out is the amount of information that's available in the tools, or could be available in the tools that we use, and in the social community more broadly. So I'll say a bit more about the tools, because I understand that you are about to deploy EPIC. You have deployed EPIC, even better. So have we. And a couple of weeks ago, I'm a general internist, and we actually went first, along with the family physicians and the general pediatricians and women's health folks. And this is, we're, I think, at wave 4 now. EPIC just got to oncology and neurology, and they're holding off with the surgeons. I don't know quite when they plan to get to the surgeons, but that's coming. But the conversation that I was part of that I found very interesting had to do with structured consultation forms that are homegrown in our EPIC implementation that prompt or require, depending on your perspective, certain information for certain referrals. So if I would like to make a referral to rheumatology because I think a patient may have lupus, or I'd like advice on the management of lupus, the form asks me, has the patient had this, that, and the third test? Has the patient had this, that, and the third set of symptoms? And in the case of treatment, it will say, what have you done before? Now, when this was explained to my division, I'll admit that people went more or less nuts. And the way it was perceived is they're making us do more work, and they're having us tee up the consultation so the subspecialist, there was actually a lot of anxiety about the subspecialist declining, saying, there are not enough boxes checked, I'm not accepting this patient for consultation. I actually took this idea in a somewhat different spirit, because it is also possible to frame this as using the tool, the consultation request, as a locus to embed knowledge. So I don't have to carry it all around in my head. And that's not a bad idea. That's a contemporary idea and a clever use of the electronic record. So once you move beyond tools where the information is already embedded, the availability of all this information, knowledge, however you want to place it in a hierarchy, raises a question of how well we prepare ourselves and our students to know when they need to go outside what they have in their heads to scaffold and support their decisions. And this is some nice work done by Charles Friedman at the University of Michigan. And the point that he's making here is simple enough to visualize on this 2x2 grid. It's great if what I have in my head leads me to the correct decision and I know it's the correct decision. But it's actually not that much worse, seen from this perspective, if what I would do unaided is wrong, but I don't have very much confidence in it. At some level, I know it's wrong. That's that calibrated OK in the lower right-hand corner. I know I'm wrong, so I'm less likely to proceed unless I'm just temperamentally dangerous. I'm less likely to proceed without bolstering my decision somewhere. Where there are problems are in the two miscalibrated quadrants. And we pay a lot of attention, of course, to the miscalibrated unsafe, where I'm sure I know what to do, but what I want to do is wrong. But actually, miscalibrated inefficient is also a problem in the world we live in, where I know what to do, but I don't have enough confidence that I know what to do, that I'm willing to proceed. It slows me down. So this is an interesting and more complex way to think about rightness and wrongness than we often apply in medical education. And Friedman takes this a bit further and talks about an assessment that would look somewhat different from that one that I showed you earlier, in which the learner, or the practicing physician for that matter, since we are all learners, takes a first pass through the task and gets a score for what he knows or she knows in her head. The second pass, the clinician consults what Friedman calls the knowledge cloud, and that results in two more assessment opportunities. One is a process score that has to do with how effective the clinician's use of all that information out there is. And the final score is the assisted score. And we talked a bit yesterday in one of the conversations about what people are able to do with assistance, which we were talking about it yesterday in quite a different context. But functionally for clinicians, this capacity, competence with assistance, and competence accessing assistance is a very, very important issue that we have not seriously tackled yet. Last comment or point I want to make about information and how it's going to change the way we practice in 2030 is who has the information and how the ownership of the information, if you will want willing to call it ownership, changes, is going to change the nature of conversations that we have with people. So who here here has heard of Hugo Campos? That's fine. So Hugo Campos is a IT guy who lives in the East Bay, near where I live. And unfortunately, Mr. Campos has a familial hypertrophic cardiomyopathy. And because of that, he has an implantable cardiac defibrillator. And the reason that he's been in the news, and if you Google him, you will find him easily, is that he has been in a 2+ year battle with the maker of his ICD, I can't remember who it is, about who owns the data that his ICD is generating. And this is creating quite a firestorm. This is actually a graph that Mr. Campos made. I'll say a little bit more about this in a second, where he's predicting, he's actually accessing his ICD the way they would in pacemaker lab, the tech would do it, and he's predicting based on the data that he's recovering on interrogation how long the battery's going to last. So, you know, that's different, but we're already heading fast in this direction. And I have Secretary Sebelius's picture up here because in September, as some of you may know, HHS issued a rule mandating the release of laboratory information in electronic health records directly to patients without mediation of clinicians. And if you haven't begun to have that adventure in Epic, you will shortly. But we're not, whether or not we believe things that physicians are inclined to say, such as patients can't understand this, it's too complicated, I'll get a million calls because the chloride's 113 and the upper limit of normal is 112. This course is basically out of the barn. And so we're going to need to learn to manage information in our relationship with patients differently from the way we have been. Here's Mr. Campos again with a poster. He's become quite a hero for groups of people who describe themselves as engaged patients or people interested in participant care. And here he is explaining how he hacked into his ICD. So the idea that we can actually control this information, I mean, that's an old idea. Various people ascribe this to various people. I think most people think it's Stuart Brand said, the Whole Earth Catalog, said information wants to be free. Actually, when I tracked that down, he was referring to free in the sense of gratis. I hadn't realized that. I heard that phrase a zillion times, and I thought that the initial original sense was liberated. But he actually meant cheap, gratis. But the idea that the saying means information wants to be liberated is now a much more common usage of that little phrase. And I think Mr. Campos' story is interesting in that regard. And the final comment that I want to make about information has to do with a phenomenon that's already well underway, which in any other context you would call crowdsourcing, so I'll call it crowdsourcing here, where people who have a condition, multiple myeloma, it doesn't matter what condition, find each other on sites like this, patients like me, and peer coach each other. My doctor did this, my doctor didn't do that, here's a list you should take to your doctor, here's a person you should insist on seeing. So again, I mean, this is what happens when information gets out there. And just so I'm not misunderstood, I actually overall think this is a wonderful thing. And the little paper that is in your reference list entitled Expert Patients Learning from HIV is a personal anecdote of my experience with this, but not with a patient like Mr. Campos. The patient I talk about had, in addition to his HIV and the Hep C that he ultimately died of, a long history of polysubstance abuse and significant schizophrenia. And he was significantly cognitively impaired, but he did much better when he, and it was his idea, it wasn't mine, took his HIV flow chart and said, this is what I want my CD4 to be. You know, what do I have to do to get a good CD4, kind of a bad CD4? So I think overall, this is a good thing, but it's going to take some getting used to. So the second big change that we're going to see, and I'm going to speed up a little bit because I'd like to have a chance to have conversations, is a lot of us have this image of how the doc works with his patient. But this is already, and that's why I chose the Norman Rockwell picture, a representative of a bygone era. We already have hyperspecialization, and we already have enormously complex healthcare, and managing that to patient's benefit is going to require a much more effective team care than we currently demonstrate. And there are going to be people on the team that we are not used to working with. And this is, again, an example of the kinds of people, this trainer, this personal trainer, these people are actually moving in to the edges of medical practice. They can't prescribe, but they make all kinds of recommendations. And I think we're just beginning to see very substantial broadening of the teams that we're used to. Here's something that is well underway. When my daughter moved to Washington, D.C., she asked me for suggestions about physicians that she should establish with. She's fortunately completely healthy. I gave her a bunch of names, and of course, being a busy 23-year-old, she didn't go make an appointment. She waited until she had a UTI. And then she called me up and she said, will you prescribe something for my UTI? And cut out the middle person, right? You've got a mom who's a doctor, might finally do her some good. But I said, no, I won't prescribe you something for your UTI. You need to go be seen for all the usual reasons that doctors say that. So she called up the group that I had referred her to, and they said they could see her in 2.5 weeks. For what probably would have been, you know, even if they hadn't said this is a new patient visit, it still would have been over $200. So I said, you got CVS all over Washington, D.C. This is the perfect moment for Minute Clinic. And she went in and was seen in, you know, it took them 14 minutes to see her, it cost her $55. She knew exactly what it was going to cost. And it's a perfect Minute Clinic case. Now, physicians have fought this tooth and nail, but again, I think it's frankly a lost battle. So here is this happy family getting their flu shots in a Minute Clinic. Another reason that we will see non-physicians providing substantial amounts of care is that we already have a terrible maldistribution problem, which is only going to get worse overall as physicians continue to hyper-specialize. Because if you're in the northwest corner of North Dakota and you are a pediatric epilepsy specialist, you're not going to be able to make a living. So the more specialized people get, the more they need to be in urban concentrations, and the more people who are out there not in urban concentrations will be turning to other people for care. And in a way, because I would say the same thing about the Minute Clinic story I just told, it makes sense to have physicians working at the high end of what we're trained to do, not doing basically protocol structured care that's pretty straightforward and can be reliably delivered by a non-physician. We're too expensive. So just to kind of reinforce the point that hyperspecialization has already is well established. I'm giving a talk next week to the American Society for Colposcopy and Cervical Pathology. They're pretty specialized. And here are some of the neurologists that you can see at UCSF. So pediatric multiple sclerosis and the movement disorders. And so even small specialties, we don't have a giant neurology department, are highly specialized. The next point that I want to make is, and it flows from comments that I have already made to you, is that a lot of our interactions, in contrast to the Norman Rockwell, warm and fuzzy, right there on the bed together, are going to be virtual interactions. And it takes skill to establish a face-to-face relationship. I think it probably takes even more skill to build a strong team and reassure a patient or a parent, for example, through virtual modalities. We're going to be getting what may be a close to constant stream of biomonitoring data all the time. So, seeing all of this. And we're going to need to interact with our patients around this data over time and distance. So here's good old my chart. My in-basket's not looking too terrible here, but my chart has about 18 different flavors of message. I have no idea why that is, but 60% are the patient has a question, 20% are the pharmacy wants a refill, and the other few are miscellaneous, so I don't know why they have to subdivide them this way. But I spend a lot of time now interacting with not just patients and pharmacies, but a whole bunch of colleagues on this electronic platform. So here's a particularly complicated patient of mine and her team. In addition to me, there's the thyroid surgeon, there's the radiation oncologist, there's the endocrine guy, there's 2 flavors of cardiologist, a medical student, and an eye doc. And this is the high end of internal medicine. And I think our care and our collaborations are going to increasingly look like this rather than the Norman Rockwell variant. But some things are not going to change. I messed up my text here a bit. If anything, in this very technological world with the nanobots and the exosomes and all the interaction with through computers and other electronic media, I'm going to assert that our ability to establish real human connections with people is, if anything, more important. And there are some reasons for that. The system that we function in is extremely complicated and very confusing. And I don't need to tell anybody in this room that. It's overwhelming to patients, and a a human connection within this complicated system is a solace. Now this, for people who haven't read it, is the workflow for dealing with patient calls within Epic in my practice. So if you didn't think the system, dealing with a patient call sounds pretty damn simple. But if you actually lay out what's happening, there's all these people and all these moving parts, and this is the desired workflow. This is not what happens when somebody gets a call and does something weird with it, which just adds more people and more loops. So we live in a very complicated system in terms of how our practice is structured. This is one apolitical map of the healthcare system, writ large. Many maps that you find like this on the internet are basically anti-ACA maps. And I was tempted to show you one of those, but I'm a huge ACA supporter, and that would be at cross purposes with my health reform interest. But again, this is an enormously complicated system. My residents don't reliably distinguish between insurance companies and medical groups, which is a fairly fundamental distinction in the private side of our health insurance system. So if the residents are confused, you don't need to spend long worrying about, thinking about how confused patients may be. And the final point here is that we live in an increasingly globalized world. We talked a bit about this at dinner last night. This is actually a knowledge worker in Nigeria. So he's part of the healthcare system, and he's clearly in a rural setting using his cell phone, he looks like he's making a phone call, so he's connecting to somebody in Lagos or somewhere, or if he had it in front of him, he'd be using it to access the internet. And I've worked in very, very rural settings in Uganda, and everybody has a cell phone. And so we may be in 2030 regularly consulting and collaborating with people who are half a world away, sharing high-resolution images, and really co-managing people we have never met with collaborators we've never met. The human touch is important because so much patient care, especially with grave illness and at the end of life, unfortunately it occurs in settings like this. And we humanize the highly technical and technological feel of environments like this. We also simplify. This is actually a nice graphic done by the same Thomas Goetz, whose book I called to your attention earlier, who got a lab printout from his physician. And remember, we said everybody's going to be getting labs directly from the computer. And he looked at the lab printout and said, holy mackerel, it's got asterisks all over it. It's got all these numbers. I have no idea what it means. Can't we do something with the formatting that conveys more information than just a plain data dump? And we're going to need, as clinicians, to be engaged in that kind of simplification and structuring of information so it's useful to people. This is, again, really just making the point of the importance that I hope physicians play in humanizing the world that we will be living in 2030. We already deal with a situation, I talk to patients many times about this, in which there is kind of a disjunction between moments that ought to feel personal, if not even spiritual, and how they're handled in a medical environment. So this conversation has come up for me with patients who are experiencing difficulty conceiving. And I've heard many times, this ought to feel, this should be natural and wonderful, but there's so much testing and procedures, and it doesn't feel the way starting our family should feel. We do, and I don't think this will be a bit changed in 2030, we do deal with the most critical and delicate and important, and wonderful and terrible moments that people experience in their lives, the circle of life. And so being the person who is witness to that is, I think, continue to be a tremendously important role for the physician. Disability, deformity, and death. So this picture gets shown all the time as a representation of that kind of witness. This is an 1877 image, The Doctor by Luke Fildus. And this is the role that I'm arguing won't go away. Usually at this point I would stop and have questions and then get to my closing slides, but because of the sort of funniness of the time, I'm going to go to my closing slides so that people who need to leave can do so. So I said at the beginning, I think we need to substantially transform what we're doing in medical education. I made some points about the massive onslaught of information that we're already subject to and the beneficiaries of. But the fact that despite this self-evident proliferation of medical knowledge, we're not doing a good job, I would argue, teaching people how to manage it, how to access it, how to assess it, how to deploy it. And we're not assessing our learners and ourselves very well in that regard. I made the point that patients already do own a lot of this information, have access to it, and I think that that's a trend that's absolutely going to continue, that there's really no justification for saying it belongs to us as professionals and we'll share what we want about it. We have to teach and model effective team care. I'm not talking about the captain of the ship model. I'm talking about a much more flexible and patient-centered model that recognizes the role that non-MDs, including non-professionals, I think, are going to increasingly play in medical care. I think physicians, including generalist physicians, will be in their own way increasingly specialized. I think it's just an inevitable consequence of all that information. So some people may specialize in explainer-integrator role, but the I'll do everything you need for you all the time model of primary care, I think, is going by the wayside. And we have to become very skilled in managing virtual communications and in developing relationships with people across time, distance, culture, who may never, ever meet. And all of that is really important. But while we do that, we don't want to turn into deployers of nanobots only. That our role as mediators, humanizers, explainers, and witnesses is, I hope, going to remain absolutely central. And so I will close with a poem that I would hope every physician can appreciate. This is by a wonderful poet, Jane Hirschfeld. Bruises. In age, the world grows clumsy. A heavy jar leaps from a cupboard. The suitcase has corners. Others have no explanation. Old love, old body. Do you remember? Carpet burns down the spine, gravel bedding the knees, hardness to hardness. You who knew yourself kissed by the bite of the ant, you who were kissed by the bite of the spider, now kissed by this. Wonderful poem. So with that, I close, and I'm happy to take comments or questions from anyone who can linger a bit.
We have time for a couple of questions or comments, and I think Molly may also have a few minutes once the program is over to take your comments and questions. Let me have you pass this mic down, and please identify.
So I'm John Bell, one of the hospitalists here at UVA. So one of my questions is there's definitely going to be a lot of change now in 2030. A lot of those changes may cost a lot more money than things do now, especially. And it seems like one of the biggest drivers of healthcare change in the next 18 years is going to be money and cost. And seeing how that's going to, and as of now, in medical education, with undergraduate and graduate medical education, the understanding how health systems will work and understanding how that affects how we practice medicine doesn't seem to be taught very effectively. I'd like to get your opinion about what do you think are ways that might be improved over the next 30 years?
It's a wonderful question, and I had a conversation yesterday with Dr. Weeby, and we got to the same point, and I thought about trying to kind of shoehorn in some comments about cost. It's a huge interest of mine, and I couldn't agree more. We not only undertreat the issue of cost and the role that we play making individual diagnostic and therapeutic decisions in driving up healthcare costs, we actually, I think, misrepresent our role. I did my fellowship training in ethics, and I was taught it is never the job of an individual physician to factor in cost in making treatment choices. And I have to say, while I liked that out for a long time, I think that it's completely irresponsible in 2012. I think we need to learn to both to understand what things cost, which is no small feat. We need to be able to thoughtfully weigh cost, and perhaps the hardest is we need to be able to talk to patients about how we're thinking about cost rather than pretending we're not thinking about it. So it's an incredibly important topic.
My name is Ed Stemler. I just want to reflect on the educational component of your marvelous discussion. I had an opportunity recently to present in behalf of a 50-year class to the graduates of the University of Pennsylvania School of Medicine. And the tack I took in addressing that was to reflect on the changes that took place from the time of our graduation to what now represented contemporary medicine. Now, what were the educational factors that were operative during that 50-year period? It wasn't the structure, it was the resilience of the talents and inquisitiveness of the individual physicians that learn to adapt to the new environment. Now, I mention that only as we look at what structural changes might be necessary in terms of contemporary medical education. It raises a lot of fascinating questions, and I agree with your idea of the models that are now extant, team approach, all of the above. I don't want to recite all of them. Obviously are very important for students to see, but what they've got to realize that what they see now is almost going to be irrelevant to what's going to happen 50 years from now. They've got to learn how to go with the flow, so to speak.
Completely agree. We'll try and improve on that.
I think we can take one more before we have to close. Is there something to take out?
So about 8 years ago,
I think
any background general internist. So T.S. Eliot asked, where is the knowledge we have lost in information? Where's the wisdom we've lost in knowledge? So all of these facts are tumbling out of the labs. A lot of it doesn't matter.
Yeah. Well, and that's a very important point. And I mean, in some of the things that this guy, Hugo Campos, writes, he quotes T.S. Eliot, so he's a broad-minded IT guy.